So we are back. Thank you all for the great presentations, outstanding presentations. And now we have some questions from the audience. And I would like to start with one question to Dr. King. So Dr. King, we know that cirrhosis and other liver conditions, such as NASH, are risk factors for cholangiocarcinoma. So do you believe that the etiology of a liver condition may be a predictor for immunotherapy response? And if so, do we need to start to stratify patients in clinical trials regarding the etiology?
Yeah, I mean, so I mentioned it briefly in my talk that there may be some correlation between hepatitis profiling B and C and the outcome. Now, once again, most of the data of that is really immunotherapy is coming out of ACC, not of cholangio. Now, when we look at the molecular profiling of intrahepatic and HEC, there are differences, but somewhat similar as well. So I think that's still the work. We still need to work further to look into that, whether that's a profiling. But obviously, that's one of the risk factors that we do look at. And obviously, the further data that comes out from other studies will hopefully establish if there's a correlation between hepatitis profiling and the outcome from immunotherapy.
Great, thanks, Richard. We have a lot of other interesting questions. One for Dr. Azad from John Fung in the audience alludes to one of the key differences we see between melanoma and cholangiocarcinoma is the tendency for cholangiocarcinoma to have a very dense stromal reaction. And the question arises is whether this may be a barrier to vaccine-based therapies.
So that's a great question, and I think it's not only a barrier that we that look into immunology and immunotherapy face, but it's true for chemotherapy, it's true for targeted therapies, that there is concern about the amount of drug exposure or T-cell ability of infiltration for these tumor types. Now that said, we do see responses to different kinds of therapy, and we do have stromal remodeling agents that are also interesting that might be good agents to explore in combination with any of these strategies. So I think absolutely it's a hurdle, and it's something that we're trying to probe and figure out how best we can use some of these combination approaches that Dr. Klein kind of talked about.
Okay, thank you. We have a question for Dr. Dombrava. So Dr. Dombrava, can you discuss your thoughts about ISACs versus anti-HER2 therapies plus IO combinations?
Sure. So ISACs are immune-stimulating antibody conjugates that, just to imagine quickly, is like an anti-HER2 antibody that is carrying an immunotherapy instead of carrying a chemotherapy, and acts as a glue between the cancer cells and the immune cells, and has the potential to elicit a more durable anti-tumor immunity and really lead to activation and accumulation of myeloid antigen-presenting cells in the tumor and secretion of pro-inflammatory cytokines and chemokines, so really leading to a more durable responses than what we see with anti-PD-1 or anti-PD-L1 antibodies. So our hope is that in addition to the HER2-targeted ISACs, we will see even better responses in combination with immunotherapy with anti-PD-1 or PD-L1 antibody.
I have a follow-up question for you, Dr. Dombrava. In hepatic cholangiocarcinomas in particular, often the HER2 aberrations we see are activating mutations, not so much amplification of overexpression. And from our knowledge in breast cancer, often the antibody drug conjugates or antibody targeted therapies may not be as effective for the mutations. So in cholangiocarcinomas, which may be more likely to have a mutation, would you advocate a targeted therapy, a TKI, or antibody drug conjugate, or any particular approach in that context, whether it's a mutation or expression-based finding?
And that is an excellent question. And so the first is really to make sure that it is an activating mutation, and it is still unknown how much there is a correlation between the HER2 activating mutations and response to these immunotherapies, HER2-specific immunotherapies. However, hopefully with combinations with in between small molecules and immunotherapies, we will be able to achieve responses in that area. And there are several clinical trials trying to address that question about targeting with antibody-drug conjugates, and hopefully in the future also with the HER2-targeted immunotherapies.
So still on HER2 therapies, Dr. Dombrava, do you believe that the risk of cardiotoxicity would be very high when this drug becomes in a more advanced phase of trials?
It is a good question. Probably we will see. However, we would not expect more than what we see with just Herceptin with the trastuzumab.
There's a question I think perhaps might apply for everyone in the panel, but maybe I'll direct it first to Dr. Klein. One of the audience members asked, for the majority of patients who are not MSI, with cholangiocarcinoma, who are not MSI high and do not have a high tumor mutation burden, how would you approach, looking at immunotherapy as a clinical trial option, or would you go toward the targeted therapy instead, or a different type of, cytotoxic therapy clinical trial? Of the combination approaches, which would you favor if multiple are available?
Thank you. I definitely think, given the low response rates just with single agent anti-PD-1 or PD-L1, or also with the anti-CTLA-4 combination approaches, obviously this has all to occur in a trial setting, but I would definitely think the chemotherapy approaches with an anti-PD-1 agent might be, at least so on the glance of the fairly small data sets at the moment, the most promising treatment approach in patients with microsatellite stable cholangiocarcinomas or biliary tract cancers. But it would be certainly very, very interesting to see in the molecular subtypes how this combination of targeted agents with anti-PD-1 agents or anti-PD-L1 agents pan out, and if pretty much this addition of an anti-PD-1 agent adds durability to the response to the targeted agents as well, which we, at least from the fibroblast growth factor receptor inhibitors, now obviously the response rates in terms of the percentage of response is very, very encouraging.
Thank you, Dr. Klein. So a question for Dr. Kim. Based on the results that you've shown, very interesting results, would you recommend to start check the PD-1 status up front in addition to PD-L1?
Yeah, that's a good question. So once again, this was sort of an exploratory endpoint that we used. I think there are two main issues for checking PD-1 as a sort of a standard. Number one is that what kind of assay do you use for that? There's not a right assay to use, and we used the assay that was provided at our institution. But there's always some staining with the PD-1 with using different assays. So that's the number one issue. The second issue is tumor heterogeneity. The problem with this PD-1 is that you need to get enough tissue, not only get the tumor itself, but the surrounding environment where you're able to capture the T cells, right? So if you go to the tissue itself, just get the tumor itself without capturing the surrounding tissue, you may not be able to capture the T cells. So if you don't capture the T cells, the PD-1 is going to be negative. So I think that's the problem with checking PD-1 and everybody. So once again, it's not ready for prime time, but once again, it's just the interesting hypothesis that we generated. So obviously more work has to be done, but I definitely would not recommend that we check PD-1 on everybody at this time.
I think I'll summarize a couple of the questions that have come in and direct a question to Nilo, Dr. Azad. One is, any follow-up on the sort of previous enthusiasm over GITR and IDO1 inhibitors, and in parallel with that response, another question was regarding your vaccine data showing the combination in the preclinical models with OX40 agonists. So, of the other checkpoint inhibitors and agonists available, what do you think is most promising on the horizon as combination approach?
So, our data, especially the work done by Dr. Zaidi, absolutely supports that the use of an agonist would be the best other agent to add on to an immune checkpoint inhibitor. We've looked at OX40, we've looked at 4-1BB, and so we are hoping that that's going to be the next iteration of the study, and we're actually in talks right now to secure that agent to add to the regimen as well. IDO was very exciting for a long time. There was some data that supported it in melanoma. They moved forward in a phase 3 trial. And I think there is some thought that perhaps it was being underdosed and that was the big issue in terms of why that large trial in melanoma ended up being negative. And there is some interest in kind of trying to revive some of it and the excitement in it based on dosing. But I think the jury is really still out. And it's always hard when there's been a large study that's been negative with a certain agent. And GITR is another one of those targets. There's actually multiple other immune targets that I think that many of us have interest in, but they just haven't come together yet for us to know exactly how to use them and in what combination. And I think that that's what the next few years is going to be about. It's going to be about immune profiling and being able to figure out how to best combine these agents, and that each patient may even derive a benefit from a different combination. And I think that's what we're going to be spending some time on, trying to understand the biology better so that then we can target with therapy better.
Okay, I think we have time for other questions. So I'd like to ask Dr. Klein, if we take a look at the trials with immunotherapy for other cancers, the trials says that we can treat patients until loss of clinical benefit, irrespective of having radiological progression in tomographies or imaging. For cholangiocarcinoma, do you believe that the pattern of progression is important? I mean, we can tolerate a first radiological progression and keep the patient under immunotherapy and take a look only at clinical benefit and not on the imaging?
I just can't speak for the observations I have made with our patients, and I could certainly say I haven't seen a phenomenon like for example pseudo progression in our patient population. I think it's also less so pseudo progression, but also treating beyond progression has been not something which was in the patient population I've looked after been